Hello everyone, today we'll be talking about work of breathing. You all would have encountered a patient who is struggling hard to breathe, and this term work of breathing has been thrown around. This is a typical patient that you observe who is tripoding using accessory muscle, having intercostal recession. He is restless and agitated, possibly sweating and tachycardic. So let's understand this work of breathing in a little bit more detail. Work is defined by force time distance. So in the pulmonary system, the force is the negative force that your diaphragm and your intercostal muscles are generating, and the distance is the movement of the diaphragm. Since the excursion of diaphragm is a little variable in different places, what we can do is multiply and divide this equation by area, and what you get is pressure time volume. So the work is driving pressure multiplied by the tidal volume. In a normal person at rest, the work of breathing is about 0.35 joules per liter of minute ventilation. Power is another word that is used with the work of breathing, and power is the rate of work, that is work divided by time. So power also depends upon the respiratory rates. When you inhale, around 30 to 50% of the energy that is required for inhalation is converted to heat, and around 50 to 65% is stored as potential energy. This potential energy is used towards passive expiration. Your respiratory muscles under normal breathing use around 3 ml per minute of oxygen, which is around 2% of the total basal metabolic rate, or VO2. VO2, if you remember, is the amount of oxygen that your body needs every minute. Under resting circumstances, your body needs around 200 to 300 ml of oxygen every minute to survive. At higher workloads, your respiratory muscles need more oxygen, and your respiratory muscles can use up to 30% of the total oxygen that you are utilizing. So your work of breathing has two components, an elastic work of breathing and a resistive work of breathing. The elastic work of breathing is done against elastic recoil of the lungs and to overcome the surface tension of the alveoli. Chest wall and lungs are in constant equilibrium. The chest wall is always trying to expand outwards if there is no force generated on it, and the lungs are always trying to collapse. And at equilibrium, this outward pull of the chest wall equals the inward pull from the lungs. During inspiration, part of the energy of the chest wall is used to pull the lungs out. So a part of work done to stress the lungs comes from the energy that was stored in the chest wall. The resistive work of breathing is done against resistance to airflow. It also partly takes care of the friction between the tissues of the lungs and chest wall, and also to push the abdominal contents. We have got alveolar pressure on the x-axis and lung volume on the y-axis. The brown line shows the elastic property of the chest wall, and the blue line shows the elastic property of the lungs. As your volume increases, you can see that the elasticity of the lungs increases and the elasticity of the chest wall decreases. And the point where both of these elasticity meet, that's your functional residual capacity. When you give a driving pressure, you generate a tidal volume. The area shown in blue is the work of breathing against the elasticity of the lungs. The area in red shows the elastic work to displace the chest wall. The dark red triangle is the elastic work that was used to inflate the lungs, but that was supplied by the chest wall. As you inhale, there is an extra work needed to overcome the resistance. So the area in green constitutes work against the airway resistance. When you exhale, the energy that was stored in the elastic lungs is now used towards exhalation. This is shown in the purple area here. If you inhale at higher functional residual capacity, you can see that the elastic property of the lungs is much worse as your volume increases. So now you require a higher amount of driving pressure to generate the same tidal volume, as you can see in these two side-by-side triangles. When you are dealing with a stiff lung or decreased compliance, the elasticity curve shifts down and towards right. Now to get the same tidal volume, you need a higher driving pressure. So stiffness of the lung increases the work of breathing. The area in the green shows work against the airway resistance during inspiration, And as your airways become narrower, the amount of work done against the resistance increases. If you want to understand the mechanics, there is a very good simulation of work of breathing. The link is in the note. I would suggest you having a look at it. So to calculate your work of breathing against the elastic forces of lungs, just look at your PV loops. The area of this blue triangle will be equal to the work done against the elastic recoil. That will be half base into height of a triangle. That is half tidal volume into driving pressure. The area in the green is the work to overcome frictional resistance, and total work of breathing is sum of both. As your lungs become more stiffer, the curve shifts towards right and you require more driving pressure to generate the same tidal volume. Similarly, as your resistance increases, work of breathing increases as well. Resistance in the respiratory system depends upon the type of flow, and you have heard about laminar and turbulent flow. With lower flow rates, the flow is typically laminar, and as the flow rate increases, the flow becomes more turbulent. The transition point is governed by something we call Reynolds number, and it depends upon the density, mean flow rate, airway diameter, gas viscosity. The turbulent flow has higher resistance than the laminar flow, so you require higher work of breathing for the same airway diameter. When your patient is in respiratory distress, a lot of them are in turbulent flow, and unfortunately not much can be done to reduce the flow. You can certainly ask the patient to slow down their breathing, but it would possibly work only in anxious patient, but not in the patients with respiratory distress. So the best way to decrease the flow is to increase the airway diameter. The larger airways are more prone to turbulent flow than smaller airways. If you look at the cross section of the trachea and the cross section of the bronchi that it divides into, the cumulative sum of the area in the distal bronchi is much larger than in trachea. So your Reynolds numbers are much lower as you go further down the bronchi. Therefore, to reduce turbulence, try to decrease the Reynolds number and try to maintain your patient in the laminar flow. And the way to do it would be increase the airway diameter to slow the flow. You can see that the Reynolds number depends upon the airway diameter as well. However, the drop in the flow rates is much faster than the drop in the diameter. So overall, the Reynolds numbers falls with increase in airway diameter. In laminar flow, the resistance is inversely proportional to the fourth power of the radius. That means if your radius drops by 2 times, your resistance will increase by 16 times. Therefore, in a laminar flow, changing the diameter of the airways works a lot better. Since the resistance also depends upon the length, the way to think about it is not to add any additional circuit to the respiratory system. Turbulent flow is more common in patients with respiratory distress because of their very high flow rates. In turbulent flow, the flow rate is proportional to the square root of driving pressure. That means if you increase the driving pressure 4 times, the flow will increase only 2 times. And if you remember your laminar flow, if the driving pressure is increased 4 times, your flow will increase 4 times. So it's twice as inefficient to be in turbulent flow. Turbulent flow does not depend upon the viscosity and only depends upon the gas density. So if you are dealing with turbulent flow, which happens in most of the severe cases of asthma or COPD, what you can do is slow down the flow by changing the I time on the ventilator. You can increase the airway diameter by giving them steroids and bronchodilators, and you can use gases of lower density such as heliox, which will help your patients further. Most of the airway resistance is in the earlier part of the respiratory tract. Around 80% of the resistance occurs till the 7th order bronchi, and rest 20% occurs later. You can see by the time the flow reaches terminal bronchioles, the resistance is very low and is. This is a very nice table which shows you how the resistance changes with the order of the bronchi. The pressure drop depends upon the resistance. So higher the pressure drop, the more the resistance in the circuit. So you can see that the pressure drop is maximum at the level of trachea, and as you move towards the terminal bronchioles, the pressure drop decreases. The Reynolds number is around 1700 in trachea, and it decreases as you go further down the bronchioles. This Reynolds number is at flow rate of 500 cc's per second, that is 30 liters per minute. So you can see that the Reynolds number in trachea is not far away from 2000, and any increase in respiratory distress which increases the flow rate will cause turbulence in trachea. The airway resistance decreases as your lung volume increases, and that is because of more negative inspiratory pressure during increased lung volume causes stretching of the bronchioles, thereby reducing the airway resistance. Let's talk about most efficient respiratory rates for work-off breathing. As your respiratory rate or effort increases, there is a higher rate of turbulence, and therefore the resistance increases. To maintain a same minute ventilation, if you are breathing slowly, you need a higher tidal volume. And you remember that to get a higher tidal volume in elastic lung, you need to work more. Hence, to pull higher tidal volumes, you must perform more work against the elastic component. The total work of breathing is the sum of these two components, and it's a U-shaped curve. The lowest point on the curve shows the minimum work of breathing at the respiratory rate, depending on what resistive and elastic component are present. As your elasticity of the lung increases, that means they become more stiff. For the same minute volume, minimum work of breathing is done at higher respiratory rate and lower tidal volume. If you're dealing with increased resistance, the minimum work of breathing is done at lower respiratory rate and higher tidal volumes. This is the reason why your patients with ILDs are breathing at baseline at a very fast respiratory rate and their tidal volumes are much lower. Expiration is mostly passive and uses up the energy that was stored during the inspiration. However, if your resistance increases, your work of breathing can sometimes exceed the amount of energy stored in the elastic portion of the lungs. And dark purple area shows the extra effort that you need to make to exhale the remaining air out. A normal individual uses less than 0.5 ml of oxygen per liter of minute ventilation. However, if you start breathing faster and faster, you will see that the oxygen consumption by your respiratory muscles increases rapidly after 70 liters per minute of minute ventilation. Compare this to a patient with emphysema who requires a much higher amount of oxygen for the same degree of minute ventilation. So if your minute ventilation is 20, you can see that the patient with emphysema uses more oxygen than a normal individual. As these patients go into respiratory distress, you can see that at 30 liters per minute, patient with emphysema now is requiring around 180 to 190 ml per minute of oxygen every minute. And we talked about that in normal oxygen requirement for an individual varies from 200 to 300 ml per minute. So you can see that most of the oxygen is now being utilized to work the respiratory muscles. Elastic work of breathing depends upon elasticity of the lungs, surfactant, and lung volumes. Increased elasticity is seen in inflammatory lung diseases, pulmonary edema, fibrosis, loss of alveoli such as atelectasis, issues like pleural effusion, pneumothorax, obesity, and kyphoscoliosis. The resistive work of breathing depends upon the diameter of airways, flow rate, and the length of the circuit. The diameter of the airways depends upon the lung volumes, whether you have dynamic airway compression, secretions in the airways, hypertrophy of muscles and mucosal cells. We know that acetylcholine causes contraction of the bronchial muscles and beta-2 receptors cause bronchodilation. Resistive work of breathing depends whether flow is laminar or turbulent, and these depend upon viscosity and density of the gas depending on if the flow is laminar or turbulent. So to summarize, work of breathing is performed against elastic nature of lungs and airway resistance. Your elastic work is half driving pressure into tidal volume, and you can look at your PV loops to calculate that. The elastic work depends upon the elasticity of the lungs, lung volume, and chest wall pathology. Resistive work is dependent on airway diameter, flow rate, flow type, whether it's laminar or turbulent, and gas density or viscosity, depending on type of flow. I would suggest you look at these two references to understand this topic further. In the next video, we'll talk about how to take care of work of breathing.